النكست توك هتبقى للدكتور طارق الباز، ولظروف معينة هو هيعملها فيرتشوال، والموضوع بتاعه الدايابيتك كيدني ديزيز challenges and new insights. دكتور طارق الباز أستاذ النفرولوجي في الأزهر، وهو هيبقى معانا إن شاء الله أونلاين دلوقتي.
Thank you very much, dear chairpersons and distinguished guests. Firstly, I'd like to congratulate the board and particularly thank so much Dr. Khalifa Abdullah for giving me this wonderful opportunity to address you regarding lots of challenges. And let me start by saying nothing has changed much. Still, diabetic kidney disease is the leading cause of end-stage kidney disease. The progress to end-stage kidney disease definitely has a lot of burden regarding the treatment and the economy of the individuals as well as the society. Bad news, diabetes is still rising more and more, and maybe 25 years time, diabetologists like yourself and a nephrologist like myself will be sitting in the same Congress saying that diabetes affects 700 million worldwide. This is a projection after 25 years. That's why, although decades show the decline in the occurrence of end-stage kidney disease, yet it started to rise again due to the fact that diabetes is increasing. This is really a serious epidemic, and I regard it much more of an epidemic than the COVID-19 that we are facing right now. Just a reminder, not all diabetic kidney disease is diabetic nephropathy with the classical 5 stages of nephropathy. I guess you all know now that we have a description of another form which is affecting the interstitium and the blood vessels. And this is very difficult to diagnose, and sometimes even the decline in GFR precedes the onset of type 2 diabetes. Also, we can understand that not all diabetic kidney disease patients are going to progress like each other. That's why we need biomarkers to tell us who is going to progress more than the other. Of course, if you are biopsying your patient early or late for any particular indication, we don't go and biopsy type 2 diabetics just like that. There has to be indications such as hematuria or sudden decline in the GFR and other things. Well, if you do have a biopsy in the early stages, you may be lucky to see the classical histopathological changes with the mesangial expansion and the matrix deposition, or in the late stages in the non-proteinuric form, you would be able to see the interstitial fibrosis and the thickening of the basement membrane of the tubular columnar cells. What we already know is that type 2 diabetics who start early, I mean, if someone gets the disease before 40, there is a higher risk of acquiring complications. But is this also true for diabetic kidney disease? Meaning, if a type 2 diabetic got his disease before 40, would he have a higher chance of getting diabetes? Well, Zeng and his co-workers looked into this particular point and had studied 1,100 type 2 diabetics with early onset, and these patients also had poorly controlled blood pressure as well as a very bad lipid profile. What they found that these type of patients who got diabetes very early had a twofold higher rate of acquiring end-stage renal disease than their counterparts that develop type 2 diabetes at a later age. So being young with type 2 diabetes, particularly if poorly controlled hypertension and lipid profile, makes it more worse and makes the progression to end-stage. 3 weeks ago, we had a webinar with the president of the American Society of Nephrology, and he told us some very distressing news. We have around now 850 million people worldwide with chronic kidney disease, a big part of which is due to diabetic kidney disease, as you understand. This makes around 10% of the 6.7 to 6.9 billions of the population. Another bad news is this is related to the United States, and of course, the United States is the biggest country regarding the field of research in medicine. They are spending around $2.5 thousand in research per patient for AIDS and HIV, while only kidney disease is receiving $50. So this is a real difficulty and a real challenge for the progression of science in this field that is, as you have seen, very, very important and carries the burden of economical burden of governments as well. Well, now to tell you something about some new insights quickly. First thing I'd like to address a new insight in the pathogenesis of diabetic nephropathy. And now we understand that initially it is happening in the proximal renal tubules, and this is happening due to the binding of the RAGE with its ligand, the advanced glycation end products. This is under the effect of the accumulation of a lot of oxidative stress resulting from the hyperglycemia, also resulting in a lot of mitochondrial damage and disruption of the physiological autophagy that is clearing the cells. This results eventually in interstitial fibrosis, and how this is possibly how it starts, or one pathway at least. And this is very important finding because it has been realized that it could be a target of therapy, as I'm going to show you. The hypoglycemic drugs and the great drug pairing that we have now is wonderful. There's no excuse to control the blood sugar. I'm focusing a little bit on these drugs in the boxes because they have proven benefits beyond glycemic control, as you all know. So using these drugs in particular would help you saving the kidney from diabetes, together with being precise, and you have to individualize your therapy. And by individualizing therapy, I want you to have a close look at this table that shows you I don't have to be all that strict and target glycated hemoglobin of less than 6.5 if the patient has a severe form of CKD, or he has lost his hypoglycemic awareness, or his life expectancy is low, or he has some serious comorbidities. Then you would be a little bit relaxed to have his glycated hemoglobin less than 8, and this is what we call like individualized therapy. When you treat diabetic patients, generally speaking, have a bird's eye view and approach the patient holistically. If you're not going to control the blood pressure and the lipids and all of these things in the circles, you're getting nowhere. So it's not just about glycemia, particularly if the patient has chronic. Until recently, nephrologists were not talking that much about SGLT2 inhibitors, DPP4 inhibitors, or GLP-1 receptor agonists. They were left for the field of diabetes. But these new oral therapies with the proven benefits that you see depicted in this box has made these drugs quite favorable in nephrology as much as they are in diabetes. Such drugs would delay progression of CKD and induce some blood pressure reduction, as well as offering cardiovascular protection. I guess we are all aware of the results of the Credence trial published last year that showed us some marvelous results where there was a reduction of 30% of the occurrence of doubling of serum creatinine or end-stage renal disease when canagliflozin was used. This was very good results, although the study was not directed specifically to patients with chronic kidney disease. And also the DELIGHT study published last year showed us an added benefit regarding albuminuria if saxagliptin is added to patients receiving dapagliflozin. Naturally, I'm not going to talk about the CKD DAPA trial because it has been covered elsewhere in this Congress. I just want to tell you these magnificent results have put the dapagliflozin in another area, not only to treat diabetic kidney disease, which has become a standard of care now, but also could be used in chronic kidney disease, generally speaking. Not only the SGLT2 inhibitors, but also the nephrologists are now looking at GLP-1 agonists. The GLP-1 agonists, as you can see listed in this table, some of which can be used with rather low GFR, such as the Dula and the semaglutide. Right now, there's a call of attention to nephrology to these particular drugs. A lot of trials so far, and there are ongoing mega trials to show how they could be nephroprotective, not only nephroprotective, but as you can see in this slide, also cardioprotective. So here we are sharing the same drugs in diabetes and in nephrology with other functions and other benefits. The nephroprotective mechanism of the GLP-1 agonist may be due to an indirect effect through improved glycemic control, decreased intestinal lipid intake, improved microbiome, a lot of things like that, as well as the direct effect related to modulation of the sodium and water homeostasis, and also the incretin effect itself related to the GLP-1. Since a decade or so, bariatric surgery has become a very important tool to treat patients with obesity and associated hypertension and type 2 diabetes, and has shown wonderful results, particularly if the physician and the surgeon know how to carefully choose and select their patient. But the authors of this recent publication looked into bariatric surgery as a treatment for chronic kidney disease. So yes, it is quite achievable, the same results of retarded progression, providing that the surgeon is going to use the Rowan-Y technique rather than the sleeve surgery. This is the best way. And the effects that lead to renal protection are shown in the slide, whether related to bariatric effects, just removing the fat around the kidney and debulking this perirenal fat is very important because it's pressure on the renal vein, increasing the intrarenal vascular pressure and decreasing the GFR by time. So just simply debulking this fat would help. This is the bariatric effect. The metabolic effect is also due to the improved lipid status, the increased peripheral insulin resistance, incretin effect, and so forth. Bariatric surgery does help hypertension and naturally reducing the blood pressure, and having an added benefit to control of blood pressure would logically affect the kidneys in a very positive way. So here you have how the bariatric surgery is of help. Having a look at the therapeutic trials, there are so many. I'm not going to talk about all of these trials that tested certain molecules, certain chemokine blockers, TNF alpha blockers, and so forth. But you can see here the three major drugs related to this SGLT, and the recent trial related to the effects of dapagliflozin. Let me take you to this slide directly because it sums up everything together. You may like to target inflammation in experimental therapies where you would block the chemokine receptors. The trials that already did not show all that good results related to chemokine receptor blockers. They were associated adverse events. Maybe the pentoxifenolin in particular as an anti-inflammatory agent is of benefits, and I will show you later in the coming slide. How about the pentoxifenolin? Xanthine oxidase has been used, allopurinol. We are all using allopurinol, but allopurinol did show some benefits related to retarding the progression and decreasing the proteinuria, yet you cannot use allopurinol once the GFR is really dropping because in itself it is rather toxic to the kidney. The vasculature, we have the SGLT2 inhibitors and GLP-1. So this is the experimental therapies and the various areas where all these drugs would be working. I'd like to share with you some of the results of the SONAR trial, which was published last year. It dealt with atrasentan, which is the endothelin-1 antagonist. And honestly speaking, atrasentan, yes, and endothelin is quite good and decreased the albuminuria in patients, but this drug is really difficult to handle and difficult to use because you need to give the patients a lot of diuretics as well for fear of volume overload. If a patient has a weak heart, you're not going to be able to give atrasentan. So they need a well-designed trial in order to test atrasentan or maybe another molecule with less fluid retention than atrasentan. And this publication in Lancet just a few months ago mentioned this particular point related to the use of atrasentan and the occurrence of hospital admission rates that was increased due to the heart failure. So again, using diuretics for these patients is mandatory, and we all know as physicians using diuretic with patients is sometimes very difficult. You need to be very close to the patient or close, not, let me say close, for fear of complications related to the diuretic itself. So this is the results of the atrasentan trials. And pentoxifenolin is a drug that withstood the test of time. We've been using it in diabetics for claudication since 1982. It's quite safe, yes. And it is, the trials so far show that pentoxifenolin is very beneficial in retarding the inflammation, which is one mode of injury in diabetic kidney disease. Not only alone, but you can combine it again with RAS blockade, which would be very helpful. The good thing about this particular drug that since it does have this inherent property of decreasing the proteinuria and the progression, you can use it when you have to stop using the RAS blockade due to the decline of the GFR. So you have an alternative to give the patient something that is also beneficial in this regard. But up to now, although there's a lot of trials and there is an ongoing trial for it, it's
دكتور
not a
طارق
guide.
حضرتك فاضل لك دقيقتين معلش.
Yes, وانا هيخلصوا ان شاء الله ما تقلقش. The last trial I want to show you is called the Fidelio DKD trial, and Mark, it is the DKD and not the CKD. It is related to diabetic kidney disease. The authors tested the finerenone, which is an aldosterone blocker, receptor blocker. It's supposed to be much more potent than the predecessors and with less abilities to cause hyperkalemia. And this is just a press release showing some marvelous results where the GFR was maintained more than 40% only over 4 weeks. This is just a press release. The results of the Fidelio DKD trial will be published soon in one big congress. The last drug I'm talking about is connexin 43. It's a blocker of this particular molecule that is very important in the context of keeping the integrity of the columnar epithelium. And this is something that has been shown earlier where the rages and the ages combine together to cause this pathology. So this drug still tested in mice. We'll see the human experiments. The last point I'm going to talk to you about is the first KDIGO guidelines for chronic kidney disease. We are very happy to have guidelines at last in this regard. And as you can see, it's full of diagrams. It's 200 pages, very comprehensive. And you can see from this slide that metformin and SGLT2 inhibitors are regarded now as first-line therapy, level 1, grade A. The guidelines are becoming very helpful for nephrologists. In conclusion, ladies and gentlemen, the prevalence of type 2 diabetes and CKD is still increasing. We need biomarkers to detect those patients who are non-proteinuria and how they progress. The available drugs right now have been approved and can be used safely in patients with CKD. We can regard SGLT2 inhibitors and RAS blockers are standards of care in diabetic kidney disease, and definitely the new KDIGO guidelines will prove to be very helpful. Thank you very much, Mr. Chairman, and thank you everybody for allowing me this talk. Thank you.
Thank you very much, Professor Tarek Elbaz.